presentation. So with that, I'm happy to introduce the presenters of today's offering, Dr. Mirza Hansen and Dr. Bita Ghafouri. Dr. Mirza Hansen is an assistant professor at the California State University School of Social Work, and Dr. Ghafouri is a professor of counseling psychology at California State University Long Beach and the founder and director of the California State University Long Beach-based Long Beach Trauma Recovery Center. So with that, I'm going to pass it over to Dr. Hansen to get us started.
Hi, everyone. I'm excited to be here and share this information with you. Our work on this area is rooted in in-depth review of understanding service utilization and treatment approaches to help individuals exposed to trauma. And with that, we are hoping today to really share with you an understanding of some unique experiences that individuals face as they manage their histories with trauma. We're framing this within the understanding of and rooting it in complex trauma, and really coming to this understanding that individuals who experience multiple episodes of trauma throughout their life, and how does that culminate in how they transition into managing the additional stressors around aging. With that, we also want to highlight how we can understand what are the care priorities of this emerging aging population. So as providers, we can help support them in more of a patient-centered approach to care around not only the kind of clinical modalities we use in our therapeutic settings, but also how we can increase engagement into therapy by helping them manage those multi-layered needs that we know emerge as individuals move from later middle life to older adulthood. So with that, today I wanted to, we're going to be moving over to understanding some of the work that we do here in Long Beach, and I'll hand it over to Bita Ghafouri to do that.
Hi, everyone. It's really a pleasure to be on this webinar today. And I would like to tell you a little bit about the Trauma Recovery Center, the Long Beach Trauma Recovery Center. Our mission is to create a better quality of life by bringing mental health care, advocacy, outreach, education, and evidence-based services to diverse victims of crime and trauma. We serve approximately 800 individuals per year, and we provide no-cost mental health services. And this is available through a grant from the California Victim Compensation Board. We were the second trauma recovery to be funded in the state of California. The first was UCSF's Trauma Recovery Center, but at this moment there are, I believe, 12 funded trauma recovery centers in the state, and 4 other states have approved legislation to start trauma recovery centers, and in fact New York is one of the states that has approved legislation to start a trauma recovery center. I'm particularly happy to be on this call today because, as you will see as we move through the slides, a lot of the work we do and to serve individuals who are older adults and as they move through aging is being done at no cost through this funding from the state. So a little bit about the LBTRC goals. As you can see on this slide, we have many, many goals at the Trauma Center here. One of them is mental health services and case management, and I think that's the one that we will be focusing on most today. A second one is, we'll be focusing on partially today. A second one is research, and Dr. Hansen will be presenting some of the research that she and I have done with some of the individuals that we've worked with. We also provide education to the community on trauma. And we also do outreach, and we work with more than 100 community partners to be able to best assist individuals who come to us for a trauma. And ideally, all of this is really to improve the daily lives of individuals who have experienced traumatic events. So a polling question that we have for you is, what % of your caseload represents older adults who talk about trauma exposure? and we'll give you a few minutes to answer this polling question.
So with that, I think we'll get the results tallied up, and we'll bring that information back to the group. And we'll head into reviewing the content of today's webinar. And first, we wanted just to provide sort of a baseline overview of how we're framing complex trauma in order to, so we can all understand these concepts in the same way as we move forward in this discussion. And so complex trauma refers to this idea that there's a repeated and multiple traumatic events, often interpersonal in nature, that happen over the life course. Commonly, complex trauma is discussed around trauma that occur in early childhood and adolescence, and we also know that these also can uniquely occur in adulthood and middle life and later life. But the real crux of this definition for us is that there's this continued experience of and experiences with trauma over the life course that create a vulnerability for these individuals. And what the vulnerability is commonly associated with is these experiences with actual disability, feelings of disempowerment, dependency, that we see actual disparities around health outcomes and mental health outcomes for this population experiencing complex trauma. We know that this is commonly experienced by individuals in public health care settings. SAMHSA has reported up to 90% of individuals experiencing some form of trauma. A population-based study done in 2012 reported that 90% of older adults report at least one traumatic event in their lifetime. We also know, though, that individuals, if they report one traumatic event in their lifetime, they have increased rates of experiencing subsequent traumatic events. So that really primes individuals for this experiencing complex trauma once they have that one-time exposure over the life course. And so with that, they're having higher rates of PTSD, anxiety, and depression. Why is this unique, though, to talk about when we understand aging and the experiences of older adults? First and foremost, we know that older adults in general have experienced huge mental health disparities. They have low likelihoods of accessing mental health care compared to younger adult populations. And a part of this understanding of this disparity is because of this masking, we call it, and competing health demands. When an individual, as they age, experience more chronic disease, for example, or they have any kind of health issue coming up, they go to their primary care doctors. We know primary care is actually at a really great rate among older adults, generally compared to younger populations. However, the conversations are not generally around mental health needs because these health needs take priority. So we say there's these competing health demands. And also the managing of multiple losses as an individual enters late life. The loss around perhaps roles of work. We see retirement. We see changes in income levels. Perhaps there's actual loss of loved ones and loss of independence. So those also become complicated around someone really understanding, well, how is the person managing those losses and what are triggers perhaps in how they understand those transitions and manage them in an adaptive way that produces a meaningful experience for their aging as they age and enter older adulthood. With that, we know at a basic level that there are individuals when they aren't supported for these mental health symptoms associated with trauma, we see higher rates of PTSD diagnosis. We have more functional impairment, and we also have more frequent episodes of depression and anxiety. So those are higher for individuals who have had exposure to trauma. And this really links to this understanding of this cumulative disadvantage that we see older adults who have these lifetime experiences with reduced opportunities to access care for these needs over their life course. And once they enter older adulthood, we see higher rates for these subpopulations around inequities and disparities in how they are able to manage those increased losses and those increased health needs. And so how can we help balance this out for individuals and engage them in appropriate care, even if they have experienced some of the inequities that we reviewed earlier in their life. So as I mentioned, we know that there's a high rate of disparities in accessing mental health care for older adults. There's complications that impact their health outcomes. They actually overuse health services, creating additional drains on our systems of care. And we have a hard time coordinating those healthcare services, as well as engaging them in mental health treatment where we see this fragmentation. We also see impacts on their interpersonal dynamics. We know support networks change as an individual ages, and so how can we also improve those dynamics in order to help the functioning and maintaining a support as these stressors emerge. Generally with service use, we also know that how does an individual make choices about services and what are the barriers to that? Commonly, stigma is one of the largest factors for aging populations in influencing their decisions to seek professional care. We also understand, as I mentioned, support networks are really important and how they talk about services and support an individual, whether that be with logistics to getting to care, figuring out how to pay for care, and helping them continue treatment. Those are all factors that can really influence the service use experience for this population. So what we did in our research is really look at sort of some relevant areas that influence individuals' decisions about care. And two areas that we have started to look into are around individual coping patterns and preferences for this population, this trauma-exposed aging population, and also looking at treatment attitudes. Because of these individual-based characteristics, we felt like this was a good way to start, as those are conversations that we as providers can have in the room and really tap into understanding our clients' preferences in this patient-centered approach. So briefly, to understand coping styles and around how individuals generally work in managing their trauma, we've seen patterns among older adult populations that the research states that avoidance coping is common as individuals increase in age. However, it's least effective in managing trauma, as you can imagine. Alternatively, though, we saw conflict. We saw conflict in that other research stated that more adaptive patterns, that people actually become more proactive and direct in approaching their distress. So with these conflicts, we decided that we wanted to see what a community-based sample of the individuals that we had interactions with and how they evaluated their coping with that. And so we were able to do a study with individuals who are community-based, who are trauma-exposed individuals. And in this study, it was really focused on looking at all 18 and older individuals to see if there were differences in how younger individuals reported coping with their traumatic experiences versus individuals in middle to late life. This was a cross-sectional study, so it was a one-time ask, so to speak, where we were able to understand sort of ask questions to help us understand coping preferences by age, how much distress an individual experienced, and how that was related. We also wanted to see if there was a relationship, as I said, with changes with aging, with age groups and how they coped. So I'm briefly just going to give you an overview of this study. We had around 180 individuals in this sample, and we asked them about what different types of coping patterns or coping approaches they used, and we asked them if they used this problem-focused, very directive approach, if they used avoidance coping, positive reframing, sort of looking for something good, or if they said, no, I just give up. Now, as a background, this was all a treatment-seeking population, and so the results showed that none of them reported negative coping, which is typical given that they were both had all started treatment. None of them had actually finished their treatment yet, but they had all made the step to get services. So we weren't surprised by that. So they were mostly proactive. It was a diverse sample, mostly middle-aged, but there was a high standard deviation, meaning that they there was a large range, right, in the sample. And they were mostly low income, and all had a level of, had screened positive for trauma exposure. And what we found ultimately was that age was related with coping patterns, that individuals who were younger noted to have different levels of distress based on coping. The most remarkable finding that we found in this study is that individuals who, as they age, and older individuals who used problem-focused, meaning more directive approaches, had less impact around distress. And so this graph kind of shows, if you see that blue line, it shows that individuals who did not use problem focus had a higher level of stress around their trauma versus the green line, who said, yes, we use this problem-focused approach, and they actually had a steadier level of impact of the stress from their trauma exposure. So with that, what we found was that this really called to light as practitioners that we should ask, first of all, sort of where are you at, what are your preferences, how can we work with you to support that, and seeing if this more directive approach can actually buffer how the experience with trauma will impact your outcomes through the treatment experience. And as we can talk about that and really refine those approaches within the clinical experience, we perhaps can help have more sustained engagement in the treatment, because we'll be rooting them in their own preferences, but also in their outcomes for care. So with that, we have a question for the group. In thinking about how coping preferences within your client population present themselves, do you have any thoughts around how we can adjust for this thought when we think of cultural considerations? Each of our clients come in with their own cultural backgrounds, and that could be around identity, it can be around ethnicity and race, their family context, and so we thought that would be an interesting kind of interaction to understand about the group. I'll just leave a little bit, 30 seconds for that, and then we'll move into the next review. Okay, and from my understanding, we'll go over some of this at the end. So thank you for sharing that information with this group. So with the next study that we brought, as I mentioned, we looked at treatment attitudes, and we really felt that this was an important area to also to examine, but to see how individual treatment attitudes impacted how older adults and middle-aged individuals can engage in treatment, but also stay in treatment. We do know that there's high levels of dropout rates among this population in general, and how can we get them to really want to stay within our 6 sessions or 8 sessions or even our 3 sessions, right? How we believe that they can really feel the positive outcomes from their treatment experience. So we engaged in doing another study around understanding these attitudes for around treatment. We focused though on a population of 50 years and older, and really tried to see what were the interactions with these concepts of well-being and how this we also use a trauma-exposed community-based population who overall were diverse and low-income individuals, and they also had not begun treatment yet, but they were also treatment-seeking population. So with that, taking in this idea of really looking at well-being from these 4 different dimensions of how individuals engage around their health, experiences with poverty, discrimination, how they can find meaning in their activities, but also in their relationships, and trying to pull these together through this research. We did this through what we call a mixed methods approach. So we did it at 2 levels. One was using a quantitative data set of the population that I described. It was 165 individuals that answered questions around their quality of life and also their attitudes around treatment. We used standardized scales for both of those. And then I had the opportunity to engage in doing individual interviews with a subsample of those individuals. Those were 12 involved, semi-structured interviews where we also asked them about sort of their treatment attitudes and well-being. And also wanted to know from those individuals sort of what are your thoughts and ideas of how we can support treatment engagement for middle to older age trauma-exposed individuals. And what we, as I mentioned, we used these standardized scales. What we found overall was that this population, because they were a treatment-seeking population, they did have somewhat of a positive attitude toward treatment, but there were some unique associations with their quality of life and sort of their priorities within how they understood treatment and their attitudes around treatment. And what stood out the most was that these individuals really noted that their environmental well-being, which has to do with concepts around financial resources, physical safety and security, how common they had access to care, their housing, and how connected they were with the community. So all those domains were encompassed in this environmental well-being, really stood out as the most relevant for this sample in how they, in influencing their attitudes towards seeking psychological help. And as a review of who was in the sample, a lot of why environmental well-being came forward as important kind of made sense. They were a low-income population who were in a high-crime neighborhood, had experienced a high level of assault as their most common type of trauma, both physical and sexual assault. And so safety around that was a common theme for them. So as I mentioned, this environmental domain became the most influential in increasing their attitudes. And interestingly enough, the social domain around well-being actually decreased their attitudes. And the way that we understood this was that individuals really looked at who in their network was supporting them, and perhaps their communities or their families or their friend networks were supplementing their needs for treatment attitudes. And so this, Dr. Ghafouri is going to talk about sort of the relevance of social networks for this population and how they manage care. So with this, we took this information around understanding environmental issues and social network issues, and we did a second level of research in doing individual interviews, and I mentioned 12 individuals 50 years and older. They were slightly, their mean age was slightly older than the quantitative sample, but not by much, but also majority female and diverse sample. And what we found were some really interesting themes, and what I have in here is the quotes from the interviews that we conducted, and 3 really main things emerged. And the first one was that individuals talked about the impact of functioning and how that really influenced sort of how they decided to get care or not get care previously. For many of them, this was the first time they had entered treatment, even though they had talked about having trauma earlier in their life. But they didn't understand sort of what was happening. So the first set of quotes, I'm just going to kind of to respect their own way of expressing their needs. They said, depression works in a lot of different ways too, and physically it took a toll on me, and I wouldn't be able to function if I tried. To extend that, I'd be an emotional basket case, and how could I deal with work that way? So really noticing how their mental health is affecting their functioning and their capacity to just get to work was really coming forward for them. Another individual talked about how she cried. She cried out of all the anger she had, and she remembers crying since she was younger. So with this her childhood experiences with trauma and how that still carried through into her adulthood as well. The next area that was discussed in a lot of relevance was the noticing of decreased capacity and helping to manage their mental health. And they said that when you're younger, you have more faith. You think it's more easy to have faith, but when you're old, you start saying, okay, I'm not the same anymore. You have more problems in your body because it's not the same. So dealing with the stress became different for this person with their trauma as they got older. And the same for the next individual, said that the stress became a little more heightened because of age. You have to make your life whole again. You see your life as shortened. You don't have extra time like you did when you were younger to move forward. So reflecting back, that this individual talked about, I knew I had this stress, the trauma exposure was affecting me, but I was more hopeful when I was young. Now that I'm older, I'm not so sure how much time I have left to manage that. So really questioning as age emerges where the coping can move forward in that. Next was barriers around care. Those were really discussed around the lack of knowledge. This person said, honestly, I didn't even know that I was being traumatized. People our age don't think that. They think kind of that they're supposed to know how to handle it. In continuing that theme, this individual, the next person said, you want to ask for help, but you're ashamed because you're of a certain age. And at a certain age, we think, oh, we're not supposed to be abused. This individual was leaving for the first time in an abusive marital relationship. And so there was a lot of shame for her in her mind, just dealing with this now. However, moving to treatment and feeling that empowerment of giving herself the chance to move on was part of her experience. And again, the next person said, the age thing is still there. You're older. You should know better than this. So really this idea of what our society kind of frames of what older adults are supposed to, if you could see me, my air quotes, are supposed to know, and how we associate wisdom and strength or knowledge with aging. And so that may counteract how individuals believe that they can move forward and talk about their needs for support. Can really be an important factor within this process of serving trauma-exposed individuals who are entering late life and in late life. Individuals lastly talked about really they felt the most important factors to get help for this population within trauma services with education, letting people know what trauma is and how it affects someone and that there is help. And interestingly, we talked about possibly doing peer-based support, knowing that I could see someone like myself who came out the other side was really important for them. And whether that's through outreach or even doing peer support groups. So in summary, I think that this work really, the second study really drives home is, bringing home and connecting individuals around sort of financial security, managing connections with community, and helping them support their needs for safety as they emerge through late life transition. And in addition to the therapeutic work that they're doing with their therapist. Social connections, too, need to be understood as providers, sort of what is the influence on their commitment to treatment and how they can engage in services. And with that, this really calls home sort of this patient-centered approach to supporting self-care as we work with communities who have these vulnerabilities. And so we're doing some work, and Dr. Gafouri is going to talk about some of this as she reviews the clinical considerations, but we are developing more of these patient-centered strategies and looking at how we can incorporate these peer support models or community health workers to support care and treatment for this population in general. So with that, I'm going to move to our next chat question for the group, and please share your thoughts, and as I mentioned, we'll go over this at the end. But from a provider perspective, how can you adapt your current outreach or treatment models to engage this population given these express care priorities that we've reviewed? And any thoughts you have that you may be already doing that we could share with the group, or ideas that maybe you have that we can also share. Okay, with that, I'm going to hand it over to Dr. Ghafouri.
All right, so I'm going to talk to you about some clinical considerations, and these are mostly going to be coming from our work here at the Long Beach Trauma Recovery Center, and I've been able to talk to some of our clinicians and gather some perspectives with respect to how we are implementing trauma care with our older adult population. So one thing that's come up is autonomy. And the fact that our older adults do have a right to their own autonomy, and that needs to be respected. And I think that one of the things that we've really come to know is that the meaning of growing old really does vary, and it's very important to get that meaning from the client, and for the therapist to recognize and monitor their own biases, attitudes, or beliefs about aging. Marissa, are you going to move it to the next slide?
Oh, you have the presenter
oh, I do. Okay. All right.
option now.
Okay. Okay. So older adults may experience symptoms more somatically than younger populations. We have found that sometimes when our older adult populations come in, they do talk about some of the physical symptoms that they are associating with stress more so than direct recollections of a trauma. And so it's really important to pay attention to that as possible signs or symptoms of some of the issues that may be associated with trauma. Our older adults have a higher risk for suicidality and self-neglect. For example, refusing to eat, medication noncompliance, or substance abuse. And these are all things I think to be aware of when you're doing treatment. When we do our initial assessment at our intake appointment, we usually do directly assess for suicide and self-neglect, so that if necessary, we do incorporate that into the treatment plan, and also incorporate case management as needed to monitor for these types of issues. Older adults are just as able to experience successful treatment and symptom reduction as anyone else. And in fact, what we've noticed is sometimes when people come in, and as Marissa mentioned, it's challenging sometimes to come in, but once people do come in, they actually are quite motivated to engage in treatment. And at the Trauma Center, we offer several of the evidence-based trauma-focused treatments, such as prolonged exposure, a cognitive processing therapy, narrative exposure therapy, and our data indicates, now that wasn't part of today's presentation, that people do very well with these evidence-based approaches and do have significant symptom reduction. Because older adults have greater risk of health concerns, it's important to work in collaboration with the client's MD or medical care team during treatment. This is something else that I think is really important because when making a decision with respect to what type of treatment to offer an individual, health concerns are something to consider. For example, with prolonged exposure, if a person has heart issues or high blood pressure, it may be dangerous for them to engage in this type of exposure. So a good connection and collaboration with the MD is essential, I think, in terms of being able to do this type of treatment. Other clinical considerations. Depression is not the same as grief. And interestingly, sometimes when we do get patients who come in, they may tell us that they have grief or depression, but they don't necessarily know that they are very distinguishable. Elder abuse is common, so that's something to certainly monitor. Family members are more likely to abuse elders than a nursing home, and elderly individuals are more likely to protect their abuser. Oftentimes that may be a child that they're living with or another caretaker, and they may legitimately fear that exposing this individual would potentially put them at risk. So it certainly is something to keep in mind. And then older adults may subscribe to stigmas and stereotypes about mental disorders. So it's really important to validate emotions, normalize experiences, to praise the client for taking the first step, and recognize the client's strengths. In fact, I can easily recall a case where we had an individual who came to us. She was in her 70s and had a very, very serious fall that really debilitated her. And her daughter was the one who brought her in for therapy. She was self-identified as Hispanic, and she really was not open to coming to therapy. But once she did come in and we worked with her for a while, some of the stigma and the stereotypes associated with having mental disorders were openly discussed, and I think that really helped. And she was able to actually open up and talk about several different types of traumas that she experienced throughout her life, and eventually the link between that and then the fall that she had that actually brought her to therapy. So I think validating her emotions was very important, and of course normalizing her experiences, and of course praise. Okay, other clinical considerations. Delays in cognitive functioning or cognitive impairments may require adaptations. For example, a slower pace in therapy is sometimes needed. If you do an evidence-based therapy, or if you have a time-limited therapy model that you are engaging in, this is something to keep in mind. I know at the Trauma Center, a lot of our evidence-based models are offered in a 12-session format, and sometimes we need much more than 12 sessions to be able to do it. So it's important to keep in mind how much a person can do in a particular day. Sometimes it's important to use simple language. Sometimes frequent repetitions and summaries of concepts are required. Every once in a while, it's helpful to record the session and give the client the recording to listen to if they choose to listen to the recording between sessions. That can actually help with trauma processing as well. Sometimes it's helpful to have the client take notes during the session. And actually, there's an emerging body of research to support the idea that taking notes helps to process traumatic events. So this might be a really helpful thing to do. Sometimes it's helpful to encourage a client to set alarms for carrying out therapeutic exercises like breathing. If necessary and with consent, you may include caretakers in the session to assist the client. However, research indicates that although the likelihood of cognitive disorders increases with age, normal age-related declines in cognitive ability typically are not sufficiently severe to impact routine functioning. And what that says to me is that most of the time, older adults can engage in therapy very effectively. Other clinical considerations: be patient. Older adults may have strengthened dysfunctional beliefs due to reinforcement over a longer period of time, making the belief difficult or longer to modify. So if you are doing a CBT-like approach where you're really working on cognitions, it may take a bit longer. And it may be challenging for a therapist to engage with someone who really wants to hold on to those beliefs. If resources are available, research indicates that it might be optimal to combine psychotherapy and pharmacological interventions. So providing a medication evaluation would potentially be helpful for some individuals, especially if they are open to it. And then when utilizing exposure-based therapy models, take time to develop effective coping skills, such as breathing retraining, to reduce the risk of emotional reactivity, exacerbating any pre-existing health conditions. So the national guidelines for PTSD treatment indicate that there are a few models that are first-line treatment approaches to PTSD. And actually, among the models, several of them are exposure-based. Prolonged exposure, cognitive processing therapy, EMDR, these are all exposure-based models. And they are considered first-line approaches. But sometimes before implementing these types of models, if you feel like that is appropriate, helping the client to develop coping skills would be quite helpful. As I mentioned before, consultation with the MD might be particularly helpful, particularly if you are considering exposure-based therapy. And if the MD doesn't necessarily think it's a good idea because of other health conditions, DBT or CBT might be a good option. And then there's some recommendations for providers. Trauma-focused evidence-based therapies are considered first-line approaches. And I mentioned a few of them. Clinicians should monitor the needs, strengths, and limitations of patients to engage in these types of therapies on a case-by-case basis. There is very little evidence to suggest that an individual who ages is not able to participate in these types of therapies. So it's helpful to assess individuals individually, coordinate with psychiatrists as needed. And then, of course, outreach approaches are helpful. Community health workers and peer support models to build on increasing social support networks and help with patient navigation. There are some current screening instruments for trauma, and they may not attenuate for the unique presentation of symptoms in older adults. Therefore, consider contextualizing the assessment tools to correctly interpret needs. I know at the Trauma Center we routinely give screening instruments before we engage in therapy and then throughout the process of therapy. And we ask our clinicians to look at these instruments very carefully because sometimes, for various reasons, people don't necessarily fill them out accurately or adequately. And so they may not be the best gauge of needs. And just in terms of recommendations, maybe it's helpful to just go over this verbally with your client if you want to get specific types of information. Case management services to secure basic needs that include healthcare, housing, food, and caregiving as needed to manage multiple losses experienced in this life stage is certainly recommended, and collaborative approaches that coordinate between primary care doctors for support management of comorbid health needs is also a recommendation that we have. And I think that concludes our presentation. We would like to answer questions. We have about 15 minutes left. Marissa? Did you want to say anything?
Yeah, I'm here and open for questions. Or Brianna, if you want
Yes,
to come in.
I'm happy to jump in now. Thank you so much for that presentation. Before we get into some of the questions that came in, I want to go back to some of the discussion questions, so maybe we can spark some conversation around that because we did get some good comments. So for the first discussion question that was, how do coping preferences interact with cultural considerations in service delivery for this population? We had one participant say, some cultures do not accept mental health treatment as an option, regardless of age. So I wanted to pose that to you guys to see if you have any comment back.
Yeah, I just wanted to say that I think it's how we frame mental health treatment. If we go in calling it mental health treatment versus saying we're looking to provide support, or if we look to modify the approach that is amenable to the individual, I think those are our forms of entree. I completely agree that perhaps putting an individual into a 12-session exposure therapy setting may not be productive. However, as Dr. Ghafouri highlighted, there's other models that we can use, and psychoeducation is probably the first and foremost approach, and it really does have a great impact on helping individuals to find supports for their symptoms and making decisions about any next steps. So I think that that's where the skill part comes for all of us in how we decide and can and provide services to our clients. And Alvita, if you want to add to that.
I'll just add a little bit to that as well. So I completely agree, but I also want to say that at the Long Beach Trauma Recovery Center, we have quite a lot of our population that we serve are monolingual Spanish speakers. And then, of course, we have in Long Beach, we have a very large Cambodian population, and so we also serve the Cambodian community and, of course, many cultures which are representative of Los Angeles and California in general. And so we interact with individuals from all different cultures and who come in with stigma and I would say quite a bit of fear with respect to engaging in therapy. And so we oftentimes start with psychoeducation about therapy in general and how it may be helpful, and really spend a few sessions to build trust and getting to know our clients. And that we found has been quite helpful to us. And in terms of our dropout, interestingly enough, our monolingual Spanish-speaking population has the lowest dropout from therapy than any of our other populations that we serve. And so we do believe, in terms of our clinical staff, that trust-building time that we engage in and really kind of explaining what therapy is and really kind of reducing the stigma associated with therapy is part of that. Might be a really great first step before engaging in any trauma-focused treatment.
Wonderful. Thank you so much for elaborating a bit more on that. I'm going to revisit the second discussion question, too. So that question was, from a provider perspective, how can you adapt current outreach or treatment models to engage this population given expressed care priorities? And so a couple responses that came in spoke about, in studies around aging, mobility appears to be an important issue, so walking groups can be therapeutic. Another response that came in said, meet them where they are and not just try to fit them in a cookie-cutter model and push them where they want to be, where you want to see them. Help them meet their goals as they want to. So any other feedback around that?
Well, I think I generally agree with meet a person where they are. I think that's probably a great place to start. Interestingly enough, when we get our clients that come in who are older adults, we do spend time kind of meeting them where they are, but we also, become quite aware that maybe they've engaged in other therapy in the past, and they may have various perceptions about the utility of therapy and the helpfulness of therapy. And so I would say that we do a lot about asking people what they really want to get from therapy and helping them to meet their goals in therapy as well.
Wonderful. Thank you. So we have a few questions that have come in. The first one is regarding a study, and Dr. Ghafouri, you did respond back to the person who did submit this question, but maybe if you could just elaborate so that the whole audience can also hear. The question was, how does race, gender, identity, economic means, sexual orientation, and other points of intersectionality impact these studies that you conducted?
Yeah. And so I think the answer that I gave was that we actually did assess all of those domains. And Marissa, maybe you want to talk a little bit more about that. But we have demographic data, and the majority of the individuals in our sample self-identify as Hispanic. And then we have I don't remember the exact percentage, and maybe you do, Marissa, with respect to the other races, ethnicities that identified. Most of the sample is very low income, under $12,000 a year. And I don't know that in that study we identified sexuality or identity preferences, but I know in the center we have assessed that on a routine basis, and we have about 12% of our population self-identifying as LGBTQ. Marissa, do you want to say more about that?
Yeah, in the two studies that I presented, we did not include concepts around identity specifically as they were there as predictors. However, they were not relevant overall. They didn't show up as significant statistical predictors around coping decisions or around having a direct impact on treatment attitudes. However, the samples are fairly diverse, and so that's probably statistically why they didn't emerge. But we do know that generally individuals' backgrounds around their identity do impact sort of how they decide they want to pursue treatment, understand treatment, decide what that means in their life. And so that's part of the reason why it motivated us to do that qualitative study, because that in that mixed methods, in the second study, using a mixed method approach, you can really get at individual experiences, and this identity component is really relevant to that. And that, as I showed in the presentation, we also did have a diverse sample, but one that did not account for specifically sexual identity, as for the samples that I was using in those analyses, there wasn't a significant number of individuals. But that's definitely something that we can try to see how we can pursue further in future research in a more direct way, I think.
Great, thank you so much. The next question that we have is, have you used EMDR with this population?
So at the Long Beach Trauma Recovery Center, we have not. We've used prolonged exposure, cognitive processing therapy, narrative exposure therapy, CBT, seeking safety, and then more of a supportive style of therapy.
Great, thank you. Another question that came in is, do you have a link or a specific study that you can identify and share that backs up the assertion that older adults might need longer interventions and also are more successful if work in partnership with the doctors? Someone is working on a grant application, would love to cite that specific assertion.
I can talk about the working with the doctors. It's based on the collaborative care approach to services for older adults, and there are a wide amount of studies that show that. And in the slides, we do have citations included. They're smaller font for space, but they are included, and those should be helpful in trying to find support for that idea presented. And I think the same for what Dr. Ghafouri talked about around how to modify the standardized treatment protocols as well. But Bita, I don't know if you want to add anything.
Yeah, I only know of the citations that you have provided in the slide. And then with respect to the longer care, I don't personally have another citation except for the CLAP study, which is in the slides as well.
Great.
So that recommendation is in the CLAP study.
And the slides will be posted on our website, ctechny.org, in 2 to 3 business days. So you can check back there to see and download a PDF of the presentation slides. And then our last question that we have, so this is specific to the LBTRC. What does your setting look like? Are there group rooms, individual sessions in offices, conference rooms? Is it drop-in or referral?
Okay, so the LBTRC is a community-based clinic. We are located in the education building of a hospital, and we've intentionally positioned ourselves in this location because this is the high crime area of Long Beach. So we wanted to be accessible to to individuals who potentially might be most in need. We have one small conference room. We have 8 offices. And we have, of course, a reception area, and we have a student room. We train students on how to do evidence-based therapies at the LBTRC. So we usually take about 8 to 10 graduate students per year in our training program. We have a psychiatrist. We have 2 psychologists. We have a social worker. We have many marriage family therapists, LPCC, who are either associates or in training as well. And in terms of drop-in, we do take drop-ins. However, the main model is that people call in. They're screened by phone by a brief screening. We usually try to get them in for a consultation appointment within 48 hours. And then we set up an individual intake appointment for them and provide the therapy with the same individual who does the intake appointment for them.
Great. Thank you so much for that response. So I want to let everyone know that if any additional questions come up following today's webinar, you can please feel free to email us at ctac.info@nyu.edu, and we can make sure your question is directed to the right person. So I just want to highlight a few upcoming events that are coming up with CTAC. We have a webinar tomorrow morning, diagnostic classification for the 0 to 5 population. We have another webinar in the afternoon tomorrow, suicide prevention among school-aged children at noon. And then another webinar, I'm sorry, those say July, but it's June, so June 27th is those webinars. And then our next webinar in July is on the 18th, Identity Bias and Cultural Humility, Connecting to Ourselves and Others. So you can visit our website to register for those events. And I just want to take a moment to thank our presenters, Dr. Hansen and Dr. Ghafouri, and thank you everyone for attending today's webinar. Again, feel free to email us if any additional questions come up, and we can be sure to direct that again to the right person. Once you leave today's webinar, you will receive a survey on the presentation, so we would greatly appreciate it if you can complete that survey and provide your feedback. So on behalf of CTAC and our presenters, I want to thank you for joining, and have a great rest of your day.